So our next lecture is from Dr. Preeya Desh. She is a board-certified palliative care physician who previously worked as a pediatric hematologist-oncologist. She works with Vitas Health in Pompano Beach, Florida, and is the program director of their hospice and palliative care at Broward Health North. She's the founder of Wabi Sabi Health, a nonprofit that teaches and trains medical teams globally using expressive art therapy to bridge cultural barriers. Dr. Desh, thank you for being here.
Hey, thank you for having me. Okay, let me see if I can get my thing to share too. Okay. Are you seeing that? Okay, great. Okay, yeah, let's jump into this. So that was an excellent segue foundation for everything that we're going to talk about here. So this is Communication 101 Boot Camp Edition. So usually when I teach communication classes or courses, I try to keep it really small and actionable, where you just take a little bit at a time so you can actually get to use this skill. But this is boot camp, and everyone knows boot camp means you get all of it all at once and you go hard. So we're going to do that. And I think that's okay because you're at the beginning of your fellowship year. Congratulations, by the way. And what that means is some of this is new for a lot of you. And so, sometimes repetition is key. So if I put stuff out there and you don't get to use it until later, I think that's okay. But at least you would have heard it. There we go. Okay. So the objectives for today are to review the need for skills for difficult conversations, and just kind of naming it, what we need these skills for. So things like goals of care, conversations, breaking bad news, prognosis, code status, and then to introduce these communication skills. So we're going to go over 3. And like I said, this is a lot for one talk. Actually, there's one more I threw in there too, a lot. But I want you to hear it and be able to identify 1 or 2 things that you feel that maybe you can practice. So that would be maybe your objective for yourself, is to really just jot down these mnemonics. Your faculty attending will probably ask you these and ask you to practice these. But you yourself, if you can find 1 or 2 things, say, hey, I really want to work on this, that would be amazing. If we have time, I have just a practice session where a drill that we can do at the end. Okay, so, sorry, this is so big. Okay, I'm sorry for that 1 second. Okay, so when do we need to use communication skills? Now, I put this picture of this little toddler here because this is probably my own on reflection of when I was trained in communication skills and palliative care. So as Ben mentioned, I did peds oncology before this, and had led plenty of family meetings. And honestly, I think I've been talking before I should have been talking, probably closer to have always thought I was a pretty good communicator. And when I went to fellowship, it was a really rude awakening where I was like, you're going to have to unlearn all of those skills. And I'm going to teach you what you did wrong. And I'm going to give you feedback on what you did wrong. The big F, capital F word, feedback. You're going to love it in fellowship. But with this, I realized that I had to unlearn a lot of things so I could learn new things. And even though I knew how to communicate in some capacities, I didn't necessarily have the skills. And so these are kind of some titles of things that we could use communication skills for. So we do have goals of care conversations. We have conversations around breaking bad news, prognosis, code status, changing care plans, changing clinical situation, and sometimes family coordination. I put difficult family in there in quotes, but then we never call them difficult families. So just family coordinations. We know who they are. We know that comes up. But just knowing that this is something that we all need to learn. So when I think of communication, when I talk to other subspecialists, I'm like, hey, we're really learning how to communicate. I get blank stares, right? It's sort of like, okay, but I want us to think of communication as your surgery, right? This is where you're picking up the right tool for the right moment, and you're learning how to use it effectively. It is something that you will in your training programs wherever you are um, be evaluated on and really kind of like dissected into, were you able to use a nurse statement, were you able to lead a meeting, were you able to do this, and seeing if you can pick up the right tool. And as I said, this is our surgery. This is our surgical procedure. Two things come up when I see this picture. You know, the first is I had an attending that I worked with who he was a surgeon in his previous life, and he would always say, you know, the night before a big surgery, I would have out my anatomy books. I would refresh myself on, you know, where that nerve kind of crosses over that bony prominence, or where looking at the patient specific scans, and he would prep for it. And he said that he would take communication this seriously, where for him, it was really sitting with this conversation that's going to happen and planning for it and looking at it as a skill set. The other thing that comes up when I see this picture is I remember when I was an oncologist that, you know, I came in after a procedure and I had to do, you know, a bone marrow or an LP or something after the fact. And so we're in a surgical suite and the surgeon's left and everyone's kind of just kind of buzzing around. I have to do my procedure and I kind of tiptoe in really timidly, and I'm trying to, you know, not disrupt anything and really kind of not confident in my own skills. I think I was just a new attending, and I remember a nurse kind of like pulled me to the side and whispered in my ear. She's like, "You are the center of this. Go do this." And you know, you're the kind of saying, take ownership of this. And so I think that's kind of my call to action here. The year is starting, as you're moving forward, knowing that at the end of this year, you will be a communication expert, and not just be able to use the skills, but be able to teach the skills. So it's always good to do kind of a self-assessment. And so I'm going to just kind of give you just a couple seconds to think through where your comfort is with um, these skill sets, right? So we've been communicating all our lives. You probably been communicating in your previous trainings and maybe had some training in it. But rate for yourself 1 to 5, 5 being not 5 being I'm an expert, 1 being no skills at all on breaking bad news. What's your skill set? This is just for yourself. What about goals of care? How comfortable are you in leading a family in a goals of care conversation? Code status is a big one, right? Sometimes we get consulted just for that, where the primary team doesn't know how to have this conversation, and it's a please help. This person is going to code, have this conversation. What's our comfort levels there? When we are having conversations and providing real information about prognosis, emotions come up. What do you do well when emotions come up? What can you do better? What have you been, what are you struggling with? So right now you're at the beginning of this, and then after a full year, you'll have a good assessment. But what's going well? What are you struggling with? And what can you improve? And so as you're listening to this talk, just maybe jotting down for yourself a skill set that you'd like to work on. So the need for goals of care conversation, and you know, again, um, goes to this, that there are a lot of late referrals, right? And so a lot of patients are referred to hospice only in the last 3 weeks of life. And this probably, there's a lot of nuances to why this is, but um, there's a thought that also, you know, were these conversations had earlier? Also, missing discussions. Cancer patients report no end of life care discussions with physicians. This is quite a big number, 2012, but it leaves room for, you know, are these discussions happening, and if they're happening, are they being documented? So some of the barriers to effective conversations, you know, I'll start with training gaps right here. So only 29% of residents feel prepared, adequately prepared to effectively communicate serious news. For those of you coming out of residency, just kind of reflecting, did you actually have didactics on serious illness conversations? Were you actually given opportunities to practice? There's also the time constraints. It There's this perceived notion that communication takes a lot of time, but as we become more and more skilled in this, we'll actually learn that we can effectively communicate with a lot less time and get to better outcomes. There's also the emotional burden that there's this perceived idea that, oh my goodness, if I put myself out there, if I go into that space, I don't know that I will be able to handle all of this. And, you know, I think as palliative care physicians, sometimes these conversations are punted to us, and sometimes that's appropriate. Sometimes we can teach our colleagues also some of these skill sets as well. But knowing that when we learn how to communicate, that it becomes less of a burden because it's actually a skill. So the setting of all of this is really a lot of times we do this in the context of a family meeting, right? So um, there's a lot of different time points where we can have conversations. There will be moments where you do bedside just check-ins, right? So there's going to be times where I'm just doing a symptom check, and that's a different type of meeting. There's times where you might have to, like in clinic, right, where it's just they're coming in for a first visit or a follow-up. But then there's times where we actually need to be a little bit more intentional. And so for the sake of this discussion, I will just call that a family meeting, where we're setting aside time to really talk about what's going on. And this is where we're kind of identifying the primary intent of the medical intervention. And we were just heard in our last lecture how grounding that to context, clinical context, is so important, and discussing all the different nuances. And I think we discussed a lot of that in the last talk. So here's another nuance that kind of gets missed in our previous training that we need to bring to the forefront here, is addressing some other things besides do you want treatment or not, right? That dichotomous yes or no answer is not the best way to do it. So looking at maybe things like function. So what are their functional goals? Is it to improve or maintain current functional status or mobility? What about survival? We talked about that just recently with, is it stay alive at all costs or maximize dignity and quality of life? There's a lot of family dynamics, right? We do not exist in silos. We exist in community, and whatever family looks like for that person, that is a part of the conversation that needs to be addressed, that needs to be included. And knowing that the patient may be making certain decisions based on their their family. Also, mentation, their cognitive awareness, discussions around what is too much, what is too little, what are their goals around that. And then the psychosocial aspect as well, realizing that while we're communicating with them and we're asking them to consider what their goals are, what their changes are in the decisions they're making for their treatments, a lot of this has to do with their psychosocial elements as well. A lot of challenges come up, right? And so here's some studies that address some of this. So when there is family disagreement, and there will be family disagreements, my favorite are the large families that gather from the four corners of the earth. I really actually truly enjoy this. It's a challenge to me when I get them all in the room, and knowing that they're all coming in with different agendas and different educational levels and awareness of what's happening with the patient, and you see the differences. And the evidence-based strategy around this is just to normalize differences. Families often have different perspectives, and that's okay. Then another challenge that comes up is hope for a cure. This is where I think we talked about how we're hardwired for for hope, and I do believe that. And it's the idea of reframing hope, right? So you may let's hope for the best while preparing for other possibilities, or let's change that hope to where, the beginning, early in the illness, hope meant one thing. Perhaps earlier in treatment, it was cure, as we saw, but later it might be, maintain function, or spend more time with family, or have a good death. Another challenge is reluctance to discuss. Some families and some patients do not want to discuss it, and um, there is a respect around what the preference is, and we do ask about that, and we do want to be respectful for that. Um, Saying something like these conversations are difficult or important, or I actually loved what Mel said about, you know, who, if you're not ready to talk about this, but who can I talk to that can help you? I think that kind of puts that back on the table, that these discussions need to be timely. And then another challenge is uncertainty of prognosis. With prognostication, this is another really I think one of the best parts of palliative care, kind of really digging into the disease pathologies and understanding what's going on and being able to communicate that and advocate. Um, we know that there is uncertainty, but with that, we are medical providers or medical doctors, and we can bring all of this together in a way that is more tangible for our patients. Now, these conversations are in a family meeting. It's more than just you. A lot of times, you are including your IDT team with you, and you're really getting the different elements. All of the people on the IDT have a different um, relationship with the patient, and they're coming at it from a different angle and skill set. And so, we want to include all of them. So the why. So why are we doing this? So we're learning communication skills. We're practicing communication skills because we really want our patients to have, the best patient experience. Where, again, that in that exercise of imagining your own loved one, right? I know that if it was my mom, my dad, then I would value a communication with the physician that was honoring my values, that was where they were taking time to really understand where we were coming from and working to come up with a plan that met that. There's also, our patient satisfaction, physician satisfaction, right? Mitigating the moral distress that we feel. Learning these skills, it increases our meaning in work. It helps us to really kind of curate the wellness that we do. Aside from communication, I'm a big wellness junkie, and it's that idea that if you want to be able to do this work, you're being trained in this really important thing, um, and we want to be able to do this for the duration of our careers, and for that, um, making sure that we don't get burnt out, and that is by effectively communicating. Okay, so we're going to jump into the first communication skill. And a lot of you are familiar with spikes. I think that's one of the more common ones. So I went through a lot of different acronyms, and really they're very similar. So I think whatever your institution or your preferences is fine. These are similar. I know Vital Talks, they have one that's pause. It's very similar to this. But we'll start with this. I think this is a great way to use this. Now, I use spikes for maybe earlier in conversations, earlier in interactions with patients and families, where we are kind of getting to know them a little bit, kind of giving bad news, or sharing a little bit of information. And this to me is more a family meeting at the beginning. So the spikes, again, is S is for setting, P is for perception, I is invitation, K is knowledge, E is emotion, and S is kind of the summary. Okay, so the first part is settings. Now, I'm going to go out of order here, and I started so I remember, is prepare. So this is, I think, the most important thing. And I think as a fellow, I would say this kind of take this on as your thing. So if there is a family meeting set up for tomorrow, what we want to do is really do a deep dive into the charts. We want to know what is going on and be the expert of what's going on. So not just what it pertains to us and what we've done, but what are all the other physicians saying? What are all the other team players saying? Speaking with other key members of the medical team. If there is something that does not feel clear, if there is, if the key player is the oncologist, the oncologist should either be at the conversation or you should have a conversation with them, because you don't want to miss that the most central part of it and have a big family meeting and then they come in with something totally different, right? If their messaging is, yeah, I think we can really get effective treatment around this, and you're talking about hospice, it's a waste of time and it's not serving the patient well. You're confusing them. So really understanding what is on the table and speaking to the team member about that. And then the pre-meet is really, really important. Again, fellows, schedule a meeting. If you invite all the key people that are part of the case, and then say, hey, you're going to meet 10, 15 minutes beforehand, and then, before at the nurse's station or somewhere semi-private, just what are the objectives? Making sure we're all on the same page. So, are you going to talk about code status? Is that the key objective? Is it just meet and greet? Is it to address a particular symptom, or is there a change in care plan that needs to be discussed? Really having that. Also identifying obstacles. Um, the amount of times that you've been blindsided by, the person who's in the meeting, you've invited them to this, and they're like, no, actually, I would. And that's fine. It can all come out and be played out in real time as well. But if we can kind of say, hey, this is what we're thinking of talking about, this is the goals and objectives. Does anyone have anything different to say about this? That can be addressed before and then brought into conversation a little bit more elegantly, I would say, with the family. Then it's also the actual physical space, right? This is goes without saying, a private space without interruptions, turning off the phones, putting a sign on the door, notifying staff and staff of the meeting. Participants, ask the patients if they want to participate. Ask the family who else they want there. A lot of times, the key person is not in the room. The patient may not be able to fully engage, and you're talking to the wife, but then they might say, you know what, later it's the son or the cousin once removed who is the decision maker of the family. And you really want whoever should be in the room or should be in the meeting to be there. Again, planning is going along with preparation. This is kind of where I do a self-check. We bring ourselves into the room, and I always kind of just have a moment where I, kind of do a gut check for myself, ground myself, and say, okay, this might be the most important conversation that this family, this patient is going to have, and it's maybe one of 20 that I'm going to have this week, but this is it for this patient. There is some important information, and I need to be fully present. I also try to identify any biases, right? We all come in with certain biases. There might be somebody who reminds you of someone, a previous patient, a family member. Am I acting differently? And really just laying it out. And this is the scary part of the work we do, because we have to check ourselves as well. Being punctual, I'm habitually late for everything. This is a fatal flaw of mine, but I really, really try, and I do, knowing that because this meeting is an important one, respecting the time and being punctual. So we'll keep going. The only thing I would say about this one is what are they really asking? What's the question underneath the question? Using that sixth sense to really identify what the patient and family is really asking about. It is easy with our medical training to take people at their face value. And if they're asking about blood sugar levels, to spend, 10 minutes addressing that, that's a comfortable space in our brain. Um, but really kind of going into what are they really asking? Maybe they're really asking, why is my loved one more unstable now? Why are things changing? Whatever it is, like really kind of figuring out what they're asking. Um, and I just put this in there because this is a pet peeve of mine. Stable. Um, a lot saying that the patient is stable. I teach this more to my nurses, right? But it's when somebody says stable, and you're like, oh, things are fine, things are stable. What does that mean to you? What does it mean to them? And really kind of grounding it into big picture. The second one is perception. So perception is where this to me is gold. This is where you're getting insight into what they are thinking. So please practice this, right? So this is different than the intake that we have been trained to do. When you did, rotations and every other thing in your previous training, you kind of go in there like, what's the chief complaint? And you just you knocked out those review of systems and do you have this? Do you have that? Do you have? And you go down. It's a very different energy and um, versus this is where you are asking what their understanding is. So a way you could say this is, what have the doctors told you? What is your understanding of your medical condition? What are you hoping your medical team can do for you? What is your expectation of this meeting? And really kind of using open-ended questions. Now, I always before I had to jot it down. Now with a little bit more practice, I don't need to, but I jot, like, mentally put down the key phrases that patients are using when they're speaking here, because I want to be able to mirror their language, and I want to be able to, kind of answer their question using their words. And then also sometimes, like when you're going back and looping and giving them the summary, you'll say, well, you said this and this is how, and you can use that language back for them. The I is just a really quick, it's an invitation. I think it takes 10 seconds, really, this part of it, but the why behind this is really important. The invitation in spikes is really where you are giving patient control in this moment. I put this picture here because there is this hierarchy of what happens in a hospital. Fully functional human being when they're at home, or fully able to care for themselves, and suddenly they're in a hospital bed. They're wearing a gown with an opening in their back. They are laying there, and there's people talking, down at them. It is a very vulnerable place to be. And so this one act is really giving them control, um, allowing them to regain some of that dignity, right? So it could be something along the lines of, what would you like to know? Is there anything you would like to avoid knowing? Some parts maybe too much for today. Is there any other family member? Is there anything you don't want to know? And then being sensitive to cultural and religious variations. And really, the invitation is, it okay if we have this conversation? And as was previously stated, if they're like, I don't want to know, this is not our job to shove things down their throats. That's not what this is about. Conversations need to be had, but respectfully, and in the way that the family can engage with. So knowledge is the K is knowledge, and this is the part that we are talking. So really, our conversation piece of this is minimal, and the family and the patient is actually talking more. So it really is opposite of what we're used to in the way we're trained traditionally. We ask a few questions and then we give information. And so in this way, we the perception is where we kind of let them talk. They're doing the ask. We're asking them. We're allowing them to kind of share and prompting and clarifying at that point. The knowledge is where you are going to deliver your information. Now, This is another skill set that I would encourage fellows to practice. Really, this in itself can be something that you work on. I for residents and our own fellows, I say, hey, you know what? I'm going to have you just do this piece, do the pre-work, do the setting work, and work on this. Do a couple drafts of what you want this to sound like, and we'll actually in the pre-meeting go over it, look at it, see what you're going to say, tweak it a little bit, and then give feedback after this piece is actually delivered. So when you're giving knowledge, it's with a warning shot, right? We want to let them know that here it is. We're going to give you some bad news. We're going to give you some information that might be jarring, letting you know before we jump into it. We start with the headline, and what I mean by this is what a lot of us do is in place of a warning shot, we will ramble our way up to it with little small talk. We will give a little bit of here and a little bit there, and kind of we're working through our own anxiety to get to a place where we feel comfortable saying, hey, the cancer is back and unfortunately we can't treat it. Right? That is our own discomfort. So instead, we've already asked them their perception, what they know. We've asked them for an invitation. We've invited an invitation. Is it okay if I share? And now we're going to say, hey, I'm going to give you some news that could be upsetting. I have your scan results. And then you just say it. You say it clearly. You be clear, you're concise without medical jargon. You're not rambling. You say it simply, and then you stop. Pause and check in. Ask if it's okay to continue. Be comfortable with silence. Another thing, faculty, I do a lot of like count in your head, where I will see how long our team can handle silence, and we kind of stretch it. It's like a muscle. It might be 10 seconds the first time, and then we might get to can we get to, I don't know, like 25 seconds of silence? And not that we need 25 seconds of silence in a family meeting, but again, we're building up the skill using silence and just being aware of your own body language, I'm sorry. In this knowledge part, you've now given them the information, and then you're going to give space for emotion. I do a lot of global health work in other countries, primarily in India. And there was a doctor who he was an oncologist, and I was teaching some of this too. And he said, "Oh, Dr. Desh, I don't. Nobody has ever cried for me. Not one person has ever cried in front of me." And he seemed very proud of this. And I was like, "Doctor, have you ever given them room to have emotions?" And he sat there, and it actually it really floored him that he's like, "No, actually, I haven't." And that was a challenge to him. I was like, "You're telling them some pretty awful news. Um, what would happen if you gave space for emotions?" Now, with emotions, we can use something called a nurse statement. I'll go over that in a minute. But when emotions come up, the human tendency is to give false hope, and I would say that false hope is more for yourself. Just do a bias check there. Because when you're like, oh, no, no, I'm sure it will be okay. I'm sure, you know what? That doctor, he's going to be able to, like, I'm sure he'll find something. Or you know what? Whatever it is, when you're giving false hope, it's a band aid. We never want to strip away hope. We never want to be in a place where we're not compassionate, but false hope is not helpful. And knowing that emotions are not just crying. Sometimes it's like you'll wait for the cue the crying, and all of a sudden you see like anger, and that was unexpected. Or the patient will kind of cross the arms, lean back, and like look at the door, signaling I've checked out, and I'm done. So withdrawal. Sometimes it's blame. They go back to, when I came to the hospital 3 months ago, this went wrong, and because of that, here we are. Those are all emotions, and just understanding that that is an emotional response. So another skill set, the nurse statements. If you haven't heard of them yet, you will hear of them ad nauseum throughout your training and beyond. You want to nurse emotions. And so the N is name. It sounds like you are frustrated. What happens here is, and this is from Vital Talks, this particular slide, it's turning down the intensity a notch when you name the emotion. So, they might say to you, if I say you sound like you're frustrated, they might say, I am frustrated. And now you have effectively heard them, right? You're in the room, you're tracking with them, you're noting that they're frustrated. Or they might say, I'm not frustrated. I'm so tired of this, or I am angry. They're going to tell you what the emotion is, and that's actually useful as well. U is understand, and it might seem something like this helps me understand what you're thinking. One thing that we really try not to do is use the I understand. It comes naturally. It's like, oh, I understand. I understand. No, 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 I understand. Comes from a place of empathy, and we all get that. But I don't know that any person can fully understand what that person is going through, even if you've been through something pretty similar. So saying something like, I can imagine this is difficult, or I can't even imagine, right? Um, R is respect. And this is actually one of my favorite ones. And this works, again, I'm going to put it in quotes, the difficult patient, when everyone's sort of like, oh no, we're going to go talk to that patient. I love to say, and I truly see this where I say, I really think you're doing a great job advocating for your family member. I can't imagine how hard it is to kind of stand up to the medical team like that and really advocate for uh, what is needed or what you think is needed. Respecting them, or I see how you're here at bedside, or I really appreciate how you want to be here when we're rounding, and whatever it is, that respect is, it really sort of it's an alignment tool. S is support, and I'm gonna do my best to make sure you have what you need. We're here to support you, and that goes to the abandonment part. And then E is explore, which should be in everybody's back pocket, said 5 times a day. Tell me more, tell me more. Can you say what you mean about that? Can you tell me a little bit more about why you said that? I use this in communication with my husband and my kids and all the people in my life. Tell me more. You'd be surprised that I'm not as good of a mind reader as I thought. And then S is the summary strategy, and this is really where you put all of it together. So any questions? And then this is kind of my own way of doing it. I don't know if I learned this from someone or I just picked this up, but I do kind of this 2-minute summary where I say, you told me, and so this is where you go back to the question. You told me that you were concerned about, and I literally say back to them what their concern was. The medical team told you that, so I'm bringing all the kind of the conversation in a one sentence and said, we told you that, and based on this discussion, we decided, and say that. Is that correct? And then the next step is, really, so let's circle back to this. Let's circle back to this conversation and give them a time, a week, a month, later this afternoon. Be specific, concrete, and then move on. Thank them and move on. Okay, so take a little bit of a breather here. So we just learned spikes. We went over nursing statements. That one piece should carry you through a lot of the discussion. There's another tool called Remap that we use for maybe goals of care that are later in later conversations. And I think this is alluded to a little bit in the last talk, where when we're later in the clinical course, the trajectory we know is going to be with kind of a poor prognosis. At that point, it's not really, what's your goals of care? What do you want to do? That question doesn't make sense. It's not relevant here. And so we can use something called Remap. And this is where, again, we are using the mnemonic, and it's R for reframe, E for expect emotion, M for map, A for align, and P for plan. And this is a great way to move to more decision making and get further along in the conversation. So the first thing is The first thing is reframe. So reframe why the status quo isn't working. So you may need to discuss serious news first. So that might be like a mini abbreviated spikes, breaking bad news ahead of time. Um, and then given this news, it seems like it's a good time to talk about this now. Or my favorite is we're in a different place. Expect emotion after we're in a different place and you've told them what that different place is. Go ahead and expect the emotion and using a nurse statement or it's really hard to deal with this. I can see you're really concerned or tell me more about then you're going to pivot to map and we'll go over this a little bit more detail in a second. Given the situation, what's most important for you? When you think about the future, are there things you want to do? As you think towards the future, what concerns you? So really kind of mapping it out, but from a starting point. It's not from the moment of maybe initial diagnosis or initial hope for cure. You're really mapping it out from the reframe. You're mapping it out from the place where we're in a different place now. Things aren't where we thought they would be. We need to talk about this new thing and we're moving forward. And then you're aligning. And so basically we're putting all of this together like a math problem. And then you're planning treatments that are aligned. So with the reframe, again, these are talking points. Given this news, it seems like a good time to talk about what to do now. Okay, so very simply, given this news, it seems like a good time to talk about what to do now. So we're reframing it. Another thing is we're in a different place. So this is where I call kind of the pivot point, where we are quickly changing the trajectory of the conversation. We're not going to talk about the status quo. We're not going to rehash the fluctuations in blood glucose levels or the thing that everyone has been talking about. We are going to have a serious conversation. We're going to review serious news. We're pivoting. And then with the emotion, I can see how concerned you are. I can't imagine. And remember that emotions happen faster than rational thinking. So, the most logical person, the most well-educated person. I've had doctors who have been patients and patients' family members who, and I give myself a lot of grace for this. I don't know. I'm very sure that I'm not going to be a good patient or a good family member when it's my turn. And that's okay. And that's why lots of grace for those I take care of. The emotion is involuntary, it's unstoppable. And so again, you use your nurse statements. So go ahead and name it, show understanding, show respect, give support, explore. So the mapping is, again, what's most important for you now. Okay, so this is where we realigned and now what's most important for you now. You want to map out the future, given what we told you, what concerns you. If your father, patient, other family member could see this and understand the situation, what would be his reaction? So sometimes we use substituted judgment here, and knowing that the patient may not be able to speak, and maybe healthy dad would say, "I'm a fighter. Let's do everything," but dad in this condition may react differently. Go from the life lived to the situation now. And this is the nuance and the skill set where there's a lot of grief. There's a lot of that grief, the bereavement that happens before death at during this time, and really mapping out what brings meaning and joy now. So this is one of my favorites, and it's probably too much for today. But in the mapping section, is a values statement. And I would Google this, print this out. This will be a tool to get more information, right? So before we can suggest a plan, before we can map it out and help them with the next steps, really taking the time to understand their values. So V is their vital goals, asking about their priorities and hopes. So something like, knowing this news, what is most important to you? When thinking about this future, what would you want to prioritize for yourself? And so this really is big picture priorities, and it brings their hopes into this, and it's a great place to start. A is activities. So ask about things they want to keep doing. When thinking about the next weeks to month, what would you want to be doing? Asking about these activities can help get to additional goals. So if they say, hey, you know what, I just want to get to my daughter's wedding. Well, then the question is the proposed chemotherapy going to help or hurt? And it may be help. It may be that, like I said, it like we discussed, maybe there's a symptom that can be managed by doing a little bit of treatment. It's far enough away, and that meets the goal. Then that's a different path than, oh, but if I do this treatment, I'm going to be sick and might be septic and may not be able to make the goal. And so that would be a different conversation. Limits. Ask about their line in the sand. Um, and I think I use that word line in the sand more than I ever thought I would. But it feels softer because it's not final, right? It changes as the situation changes. So, but with the information you have, what would be an unacceptable quality of life for you? A life worse than death, right? And so if somebody asked me that, I would say, if I was in a vegetative state, if I was in a nursing home by myself with nobody to visit me, unacceptable. What abilities are so critical to you that you couldn't imagine living without? I think for me, if I couldn't talk, then I don't know. Like I don't know if I couldn't communicate, I don't know that I would consider that living. And that is it's something that's different for every person, and really figuring out where it is for that person. U of values is uncertainties and worries. Ask about their worries and concerns. When thinking about the future, what worries you the most? After hearing this news, what concerns would your family member have? You'd be surprised. It might be, I really worry about my child who's physically dependent on me. I worry about my husband that whatever it is. Their worries may not be um, as um, visible as you would think. They may be something that, unless you ask, you wouldn't know. And that could actually help with additional goals as well. Experiences with illness. This is gold because we all come from, we have health backgrounds, and the way we engage with medical decision making a lot of times is based on what our experience with serious illness has been. Has anyone in your life been seriously ill or died? How has that impacted your thoughts on healthcare? I had a patient who, she was declared brain dead, but the father had just come out of an ICU situation, and for that it was so tightly linked that we had to sit and unpack the one to get to decisions on the second. How was the last time your daughter was in the hospital? Would she do anything differently, right? And sometimes tracking the progression. A COPD patient that has been in the hospital a million times, having these goals of care conversation is very difficult, because every time they're like, I've been intubated like 4 times, Dr. Dash. I've been to death and back 4 times, but what's different this time? What has changed? Was that 10 years ago? Were you in a different place physically? Were there less comorbid conditions? What's different now? And kind of tracking that as well. And then S is strength and supports. Ask what helps them through their illness. What gives you strength? What supports you through your illness? Faith, family, a hobby, whatever it is. What coping strategies do they have? Are they positive coping, negative coping, whatever that is? Now, as we are talking about all these things, just kind of to bring to the forefront is this idea of abandonment, right? And so Dame Cicely Saunders, we know her, love her. Most people are not afraid of dying as they are of being abandoned. And the worst thing we can do is abandon someone who is hurting. And that's the thing, when we have these conversations, it sometimes feels like you're not when we do it, of course, because we are trained to do this, but when other people do it who are not trained, it feels like, okay, make a decision for hospice because I need to discharge you, or make a decision for this because I don't have any more resources or skills to bring you back from the brink of death, and I need you to make this decision so I can move to the next patient. That's not what we're doing here. By exploring values, by sitting and having these conversations in that structured way, so we know how to be succinct with it and skilled with it. We are communicating non-abandonment. We're communicating that we are working to build a plan that that makes sense. And then the last part, the last two parts is align. So here is where, this is where you as the skilled physician, right? You have been trained for years and years and years. You are not just a person walking down the street. Use your medical training. You're going to put all of that together. You're going to do some medical interpreting. You're going to listen to what the patient and family have said. You're going to listen to what the medical experts on the case have said. You're going to bring it all together, and you're going to say a couple things stand out, and I can help you with these important things. So this is where it's, you're interpreting now, and you're actually saying this is what I can propose. And then here is again, aligning is affirming their values. It explicitly shows you listened. And this, in this place, you might hear a statement that comes out of left field and leaves you confused because you've just given them all this information. You told them you're in a different place right now, and they throw out something like, well, you know, we're praying for the miracle, or this person's going to pull through, you'll see. And honestly, we wish for that, we hope for that, but when we're in a situation, we can use the wish statement. And this is basically saying, this is an alignment tool. So I wish there was more we can do for you. I wish there was a way to cure this disease. I wish I had better news. I wish there was more therapy that I could offer you. So this is a way of, you know, the tendency would be like, well, there's nothing else we can do, or give them false hope. Sometimes we pivot to either extreme, but this is a nice middle way of saying, hey, you know what, I'm here with you. I really wish I had a way to cure this. I really wish there was something that I could do to turn this whole thing around. And therefore you are seeing them, and you're wishing and hoping with them, you're wishing with them, without saying yes, there is. And the last part is plan. And this is where you bring it all together. So here are things that we can do now that match your values. And this is what I was kind of alluding to before. You're putting it all together. And based on what you said, here are things you can either say we should not do, or here are things we should do. And these are recommendations. And so I don't know how the other attendings on this call feel, but I am not afraid of giving recommendations. We are physicians, after you've done all of this, all the due diligence, all of this careful curating, listening, planning, our expertise is now saying, here's, you know, what we recommend based on what you said. Talk from the positive frame first, so they know the plan, and then what you might withhold after that. Okay, so we have a few minutes, and this is the last kind of bit. I wonder if there's any questions, the burning questions now, and then I'll just do a quick drill with you if we still have the time. Does anyone have anything to add or any questions for me?
This seems really complicated. How do you keep all this in your head while you're in the middle of doing a clinical encounter?
Yeah. So, man, Dr. Johnson, that's a great question. So I think that this is an overload, information overload. Really, each of these things could be divided, this whole lecture could be divided into 6 different smaller topics. And those 6 could even be divided into really smaller drills and practice sessions. And that's how you should think of it. So if, you know, if your own personal learning objective is, you know, I want to learn spikes for the first half of the year, remap for the second, and that's a fair way to do it. And there's others as well, but it might be that in this part, I want to work on just the one. I want to work on just the knowledge. I want to work on just the invitation. I want to work on this piece. I want to work on my value statements, and this is the value statement I'm going to use. I think it's just the practice. It all comes together eventually. It feels like a lot. Like I said, I'm an intuitive communicator, and so this was really hard for me, like to learn like a language and steps. It felt wrong to me. I had to unlearn things, but I will tell you, by really just kind of keeping it simple and learning the flow of things and practicing it, it is effective and it saves you so much time. Okay. I'm going to ask for 2 volunteers to come off mute. Can I get it to just read? You're literally just reading, and this is a Vital Talks drill that we're going to be doing. Can I have, and you can get on camera too so I can see who you are.
Hi, good morning.
Hi.
I can go ahead and read.
Okay, perfect. Thank you. And where are you from?
I'm from Kaiser Fontana Medical Center. I'm one of the HPM fellows.
Nice to meet you. Thank you so much. Can I have one more person? Carol, are you volunteering?
Yes, I am. Can you see me? I just can't see myself, so.
Yep, no, I see you. I see you.
Okay, cool.
Perfect. Okay, so,
Yeah.
Andrew, I'm going to have you be the clinician, and Carol, you're going to be the patient. Now, the idea behind a drill is only that sometimes cognitively it is hard to come up with things, but hopefully you'll be practicing more drills in your education where you're at. And so you can just kind of get a feel for the words. Okay, so let's go ahead and just read. We're going from left to right, left to right.
Got it. All right.
Okay.
I like to talk about what is ahead with your illness and do some thinking in advance about what is important to you so that I can make sure we provide you with the care you want. Is this okay?
I'm doing fine right now. I don't know that we need to have a big conversation.
I do this with all my patients so that I understand what's most important to them. And I'm going to use this conversation guide to make sure we don't miss anything. Is that okay?
Yeah, I guess that would be okay.
And Carol, you have some acting skills. I like it.
You know,
Okay.
What is your understanding now of where you are with your illness?
I'm feeling better since I got out of the hospital, but I don't know there's a lot wrong with me, my lungs especially. But I'm a positive person and I know I can get through this.
In thinking about the future, how much information about what is likely to be ahead with your illness would you like from me?
I want to know everything you know.
I want to share with you my understanding of where things are with your illness.
Okay.
I hope that this is not the case, but I'm worried that this may be as strong as you will feel, and things are likely to get more difficult.
Oh, goodness. I wasn't expecting that.
This must be really hard to hear.
It is. My family needs me.
What are your most important goals if your health situation worsens?
Spending time with my family. Also, my daughter is getting married next year, and I really want to be at her wedding.
What are your biggest fears and worries about the future with your health?
I'm really worried about suffocating. What can you do to make sure I don't suffocate?
Managing your symptoms is really important for us to talk about. Can we set that aside for right now and come back to it later?
Okay.
What gives you strength as you think about the future with your illness?
My spouse is a great support, and my daughter makes me laugh and keeps my spirits up.
What abilities are so critical to your life that you can't imagine living without them?
I want to be here for my family, and I want to feel well enough to be able to do fun things with them, like going out to dinner.
If you become sicker, How much are you willing to go through for the possibility of gaining more time?
Well, I'd be willing to have more tests and treatments if they help me feel better. I don't want to die in the hospital, hooked up to a machine.
How much does your family know about your priorities and wishes?
I think my spouse knows, but we haven't really talked about it. We probably should do that.
I've heard you say that having quality time with your family and having your symptoms well managed are really important to you. Also, that it's been difficult to talk with your spouse about this. Keeping that in mind and what we know about your illness, I recommend that we meet together with your spouse to think through next steps. This will help us make sure that your treatment plans reflect what's important to you. How does this plan seem to you?
I know it's going to be tough, but meeting together would be an important next step.
I will do everything I can to help you through this.
Thank you.
Now, maybe we can spend some time talking about how to manage your symptoms.
That would be great.
Okay, excellent. And so we'll wrap up. I'm actually have to ask both of you. Thank you for volunteering. Is there anything that you saw there that you want to reflect back on that maybe surprised you, or that maybe you think you can practice moving forward?
I think like practicing a little bit more on the transitions. I felt like sometimes it was just maybe it was just because I was reading and it felt very like it was very concise and straight to the point, which was good. I thought I was expecting a little bit more of a transition or acknowledgement of what the patient was saying as I transitioned. But I think the reading was just going to the next thing, hitting. I wasn't expecting that. I was almost going to put in my own emotions, but I didn't. I was just sticking to reading the prompt.
Okay. Carol, anything that you would want to take into?
Yeah, I would agree with that. I think I was expecting more. I remember reading somewhere that asking for to transition or to move on is like a good strategy to have. So I kind of wish there was a little bit more of that. And yeah, I think the patient at once said like, this is difficult. So I guess more like of space to acknowledge that would have been good. But
Yeah. And I think both good points. So it brings up two things. One is that the skill set is clunky, right? As you're learning it, it's going to feel really clunky. It's almost like editing, almost like when you're sending an abstract and you can only use a certain amount of words. Effectively communicating actually is learning how to say less. Again, really hard for me. I want the transitions. I want to talk about it. I want to make sure you're comfortable. I'm comfortable. The backside of that is once you learn the skills, you can put your spin on it, right? So you're going to bring yourself into the conversation. You're going to make sure that it's in a way that feels authentic to you. So I don't want you to hold back on that. You're learning the skills so you can effectively do it and teach it. But then at the end of the day, it's going to be you communicating. So thank you both. So just to end, really I'm going to challenge you to practice, ask your team members to like, to watch for different skills. If you're going into a room, even if the faculty is not there, say, hey, I'm going to try a nurse statement, see if I do it, and just really keeping these skills available and practicing them. That's it. Thank you so much.